Greetings, I'm Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I am pleased to welcome you to the multimedia summary for the journal's October 2022 issue. There are 4 articles that have been selected as our Editor's Choice or Highlights articles this month. The Editor's Choice this month is an original article entitled Effects of Replacing Sedentary Time with Physical Activity on Mortality Among Patients with Heart Failure, National Health and Nutrition Examination Survey Follow-up Study. It is authored by Dr. Young-Dup Kim and colleagues from the Virginia Commonwealth University in Richmond, Virginia, as well as from the University of Illinois at Chicago in Chicago, Illinois, and the John Ochsner Heart and Vascular Institute in New Orleans, Louisiana. With such cardinal symptoms as fatigue, lassitude, and exertional dyspnea and tiredness, heart failure predisposes to a sedentary lifestyle. In the evolution of the management of heart failure, such sedentary behavior was even considered by some in the past as beneficial, as it supposedly avoided hemodynamic stress that may be imposed by physical exertion. However, abundant and growing evidence now attests to the adverse cardiovascular effects of a sedentary lifestyle. And in the present issue of Mayo Clinic Proceedings, Kim et al. Addressed this issue in patients with heart failure. These investigators examined the so-called displacement hypothesis, which posits that increased sedentary time largely occurs at the expense of physical activity, and such displacement may underlie adverse outcomes in patients with heart failure. Kim et al. Studied all-cause and cardiovascular disease-specific mortality in 265 patients with heart failure who participated in the National Health and Nutrition Examination Survey from 2003 to 2006. Activity was assessed by an accelerometer, the latter used to quantitate sedentary time, time spent in light-intensity physical activity, and time spent in moderate and vigorous intensity physical activity. The data demonstrate that for a given 24-hour period, sedentary time accounted for 70% of time while awake, but light-intensity physical activity and moderate and vigorous intensity physical activity accounted for only 29% and 1% of such activity, respectively. Importantly, replacing just 10 minutes of sedentary time by light-intensity physical activity was attended by a significant reduction in all-cause and cardiovascular disease-specific mortality. Furthermore, there was a graded risk reduction in mortality as sedentary time was progressively replaced by light-intensity physical activity. Replacement of sedentary time with moderate and vigorous intensity physical activity tended to decrease such risks, but the findings were not significant, likely reflecting, as the author suggests, the very low occurrence of moderate and vigorous intensity physical activity in these patients. While the data of Kim et al. Support the displacement hypothesis, it should be noted that sedentary behavior, in particular sitting per se, as distinct from decreased physical activity, may exert adverse cardiovascular effects, including increased blood pressure, impaired peripheral blood flow, impaired glycemic control, pro-inflammatory effects, and the blunting of the acute beneficial responses to exercise. Intrinsic adverse effects of sedentary time may thus conspire and summate with decreased physical activity in underpinning the mortality observed in patients with heart failure. These important findings of Kim et al. Demonstrate that inactivity is a risk factor for mortality in patients with heart failure, and that salutary effects may attend exchanging inactivity by activity, even when such exertional activity is relatively limited in duration and low grade in its intensity. Our first highlight this month is a review article entitled Diabetic Kidney Disease Back in Focus, Management Field Guide for Healthcare Professionals in the 21st Century. It is authored by Dr. Radhika Alachek from the University of Washington in Spokane and Seattle, Washington, and Dr. Susan Nicholas from the University of California, Los Angeles, California. Both nationally and globally, diabetic kidney disease is the most common cause of chronic kidney disease and end-stage kidney disease. The development of diabetic kidney disease in type 1 or type 2 diabetes worsens cardiovascular and other complications of diabetes, challenges glycemic and blood pressure control, and increases the risk that death may occur before chronic kidney disease progresses to end-stage kidney disease. However, the outlook for patients with diabetes has significantly improved, especially with the introduction of new glucose-lowering agents that reduce cardiovascular morbidity and mortality and diminish the risk for progressive kidney disease. Alachek and Nicholas provide a comprehensive discussion of these newer agents within the broader context of the overall management of diabetic kidney disease. The authors begin by discussing key considerations in diagnosing diabetic kidney disease and diabetic nephropathy, and the significance of albuminuria and eGFR. Then, drawing upon guidelines from various societies and a comprehensive review of the relevant literature, Alachek and Nicholas review key recommendations pertaining to lifestyle interventions, glycemic targets, glycemic monitoring, anti-hypoglycemic therapeutic options, control of blood pressure, especially by angiotensin-converting enzyme inhibitors and angiotensin receptor blockers, and lipid management. Helpful tables summarize various guidelines pertaining to screening and monitoring for diabetic kidney disease, blood pressure management, and hemoglobin A1C targets. Special attention is directed to sodium glucose cotransporter 2 inhibitors and glucagon-like peptide 1 receptor agonists. And for each member of each class of drug, the authors discuss the route and frequency of administration, approved indications, recommended dosing for glycemic control, and drug dosing in the setting of reduced kidney function. Also provided is an algorithm of glucose-lowering therapy for cardiorenal benefit. Salient clinical concerns for sodium glucose cotransporter 2 inhibitors and glucagon-like peptide 1 receptor agonists are reviewed and strategies to address them discussed. Alachek and Nicholas are to be commended for providing this lucid, timely, and instructive review on the current management of diabetic kidney disease. Our second highlight includes 2 articles that address acquisition of resistance to COVID-19. The first being the efficacy of the COVID-19 booster, the second being the importance of eliciting mucosal immunity. The first article is an original article that is entitled Effectiveness of COVID-19 Booster on the Risk of Hospitalization Among Medicare Beneficiaries. It is authored by Dr. Himal Kumar Mehta and colleagues from Johns Hopkins Bloomberg School of Public Health, Baltimore, Maryland, and the University of Texas Medical Branch, Galveston, Texas. Using Medicare claims from January 1st, 2020 to December 31st, 2021, Mehta et al. Matched almost 4,000 subjects who received or did not receive the booster over a maximum follow-up of 130 days to determine hospitalization rates in either group. The data demonstrate that the booster was associated with 81% efficacy in reducing hospitalization, and that the booster could prevent almost 70,000 hospitalizations in the currently non-boosted 15 million individuals aged 65 years or older. Factors that reduced the booster's efficacy included certain comorbidities, including hematologic and other malignancies, diabetes, renal failure, and autoimmune diseases. The efficacy of the booster was also reduced in Black and Hispanic enrollees and enrollees with prior hospitalizations. In those subjects older than 65 years, the reductive effect on hospitalization rates with boosting significantly increased with age. Boosters were more effective when given between 6 and 9 months after vaccination, and less effective if given at 5 to 6 months or less than 5 months after vaccination. This study by Mayo et al. Provides compelling evidence regarding the efficacy of the COVID-19 booster in preventing severe COVID-19. The second article is a perspective that is entitled SARS-CoV-2 Vaccines, the Mucosal Immunity Imperative. It is authored by Dr. Eli Adachi and Philip Grupuso from Brown University in Providence, Rhode Island. Adachi and Grupuso highlight the significance of eliciting mucosal IgA-based immunity as a preventive strategy in COVID-19. Parenteral vaccines are effective in reducing the risk for severe COVID-19 and attendant mortality, but breakthrough infections may occur despite being vaccinated. As pointed out by these authors, a relevant consideration is that while parenteral COVID-19 vaccines promote humoral IgG-based immunity, these vaccines generally do not achieve mucosal IgA-based immunity. The latter is important in enabling resistance to breakthrough infections and in potentially impeding the spread of COVID-19. An effective and safe intranasal COVID-19 vaccine will thus be an important advance, either administered in concert with or supplanting a parenteral vaccine. A number of relevant initiatives and studies, as summarized by Adachi and Gruposo, are currently exploring these exciting prospects for intranasal vaccines. You can access these highlights and editor's choice articles free of charge during the entire month of October. Please visit our Mayo Clinic Proceedings website at www.mayoclinicproceedings.org, where you'll find links to our social media by clicking the buttons at the bottom of the home page to follow us on Facebook, Twitter, and YouTube. On our YouTube channel, you'll find full-length author interviews called Insights and our MCP 60 seconds video article synopses. Our website also includes our Mayo Clinic Proceedings issue summary and author insight podcast recordings, which are available from our website on the home page as well as through iTunes. You will also find our online-only features and many news stories posted in News from the Editor carousel on our website homepage that are based on articles published in Mayo Clinic Proceedings. And finally, you will see other free content as well as articles published online in press. As always, we greatly thank you for your interest in and your support of Mayo Clinic Proceedings. We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.